Hi, I'm Gary Dewood, one of the resident faculty here at Spear Education. Welcome to our online CE courses, and welcome to this course specifically about Facebow transfers. You know, the Facebow was one of those tools that we learned about in dental school. Most of us used it throughout dental school whenever we were told to. Many of us, when we got out, found ourselves using it less and less. As we try to differentiate our practices and take our practice to a different level, many of us bring it back. It becomes a great diagnostic tool. And since we're always looking for ways to differentiate the practice, one of the things that I noticed when I brought back the Facebow was the comments that I got from patients. You know, everything old is new again. And when something is not used a lot in regular clinical practice and all of a sudden you are using it, that was the Facebow. I started taking Facebows of my patients so I could do diagnostic mountings. I discovered that most of my patients had not experienced this before. And I got wonderful compliments on my being so modern, so new, so up to date. By the way, this was back in the 1980s. Interestingly, the Facebow's been around for a long, long time. In fact, the first research on it was published in the middle and late 1800s. So Dental Cosmos has articles. I think this one is an 1878 article from Dental Cosmos, and there's another Dental Cosmos from 1896. The Facebow has been part of dentistry for a long, long time. Now, in those days, it was very, very important in denture prosthetics, which, by the way, was probably the main reason most of us used it in dental school. We were told to mount our case with a Facebow so that we could figure out where those front teeth were relative to the mounting, really relative to the face. That's what the Facebow does for us. Today, that same information is vital information when it comes to aesthetics. There are three main reasons that we would take a Facebow. The first one is to replicate the functional movements of the patient. The second one is to transfer aesthetic information for diagnosis and treatment planning. Third, minimize adjustment time at the chair. Now, all of these things have to be accomplished with a high level of efficiency in a busy practice. As you know, whenever we bring in new things, it slows us down. When it slows us down, we have a decision to make. Is the value that we get from adding this to our processes higher than the cost of incorporating it? Sadly, for many things, we push them back aside and we go back to doing what we were doing. With the Facebow, to be efficient, it's going to be something that you not only have to master, your team has to master. Let's talk about what you need to really be able to utilize the information that can be gathered with a Facebow transfer. And there are three things. We need accurate casts. We need a bite record of some sort to articulate the casts with each other. And then, of course, we need an articulator, because having these casts that relate to each other and having a Facebow doesn't help us unless we have a system for tying all that information together. Accurate casts is the very beginning. You know, I always chuckle when I hear people say, well, let's just grab some preliminary impressions. And for many of us, and I'll own this, in my practice, preliminary impressions for years were thought of as just that. The preliminary things we do. It's not real. It's not the important stuff. You know, preliminary impressions are a vital part in aesthetics of walking through the process of seeing the changes we can make, because the soft tissue is equally important. So preliminary impressions today for us at Spear Education become the primary first impression that you're going to take. It becomes a source of information, an important source of information. Those casts need to be accurate. Now, this course is not about getting accurate casts. There will be online CE courses about that, the different steps in getting casts. It's also important enough that it's something that we teach in our regular curriculum, and it will be incorporated in our assistant courses so that your team gets equally proficient not only at gathering casts, impressions for casts, but evaluating those impressions the same way that you would. If we have accurate casts, now we need to have a bite record. And again, this course is not designed to talk about taking bite records, but that bite record is going to be your reference point for beginning the relationship of the upper cast to the lower cast. Now, the facebow is only relating the upper cast to the articulator, to the face, to the floor, and we're going to talk about that. However, in order to really use that information, you're going to want to take a bite record, mount that lower. Again, it's taught in different courses. We talk about it here because it's a vital part of the articulator setup. Our preference today, in any joint that can be loaded, is to use a leaf gauge to allow the patient to move freely and then seat those condyles in a reference position called centric relation. From there, we can begin our planning. The third thing we need is an articulator. You probably have one. By the way, if you don't have one, there are many, many wonderful articulators out there. The one that you see here is the SAM articulator, which is the one that we use here at Spear Education. But there are many excellent systems. If you have a system that's not a SAM, it doesn't mean that you can't get beautifully accurate mountings and do great diagnosis and treatment on those. Any articulator that is semi-adjustable is going to give us the information we need for 99.99% of our cases. The facebow, the actual transfer device, is going to vary by manufacturer. Every manufacturer is going to design a system that works best with their articulator. The one you see here is the SAM earbow. It's the earbow that will allow you to transfer information to the SAM articulator. It's going to position the upper cast relative to the ear canals because it is an earbow. Now, there are three kinds of facebows. I've said that the earbow is the one we're going to use, and there are some reasons for that. Let's back up for a second and let's talk about the different kinds of facebows. The first one is a hinge axis facebow. And a hinge axis facebow is a device that is actually based on the axis that your mandible hinges. And I realize as you think, aren't they all doing that? They are. However, the hinge axis facebow is a device that is going to use more precision to find that rotating point. A kinematic facebow is a facebow that is designed for the operator to decide where that hinge point would be. In other words, you would actually go in and palpate as the patient opens and closes, find the position, and then set the facebow onto that position while you position it in the face. The last one is an earbow. Earbows are the ones that are most commonly used today, and in fact, they're the ones that we recommend here at Spear Education. It's the one that I use in practice, that Frank uses in practice, Greg, Bob, Lee, we all use it in practice because it's quick, it's easy, and it transfers all the information that we need for almost every case we would ever do. Let's talk for a minute about the hinge axis. So this happens to be a Denard pantograph. The pantograph is a device that tracks mandibular movement. The idea being that I can then take that information, apply it to my articulator, and get a more perfect mimic of what that patient can do. You might notice that it looks a little more complicated than our SAM earbow, because it is. In order to use this device, which will track everything, we have to create clutches. What it does is create a recording back by the ears as we move around. As the patient hinges, we watch that stylus, and when the stylus goes to one point as they hinge, that is hinge axis, we now lock the system down, take the clutches out, and transfer that information back to the articulator. Again, one of the problems here, even though the stylus is highly accurate, is that what you can see is that in order to gather this information, there's quite a bit of chair time involved. There's also quite a bit of non-chair time in that clutches need to be designed to fit in. Now today, we would use a digital version of those pantographs. Here are two of those, the Kadiax and the Arcus Digma. Both of these accomplish the same goal as the Denard pantograph, which was an analog device, by having the patient move and digitally gathering information that can now be applied. We still need to provide in these clutches that have to be built, so the time investment is higher. When would something like that be appropriate? Well, in a patient who has issues with their joints. So let's say that they have medial pole displacements. They now have a joint that is not as solid as it was when those discs were in the right place. It can go through movements that a normal joint would not go through. In other words, the tolerances in that joint may allow much more movement that we might need together to create an occlusion that would allow for that not to be destroyed. And so, rare case, very uncommon, but there are still times when this information is not only appropriate but necessary. This is a kinematic facebow, and what you notice is that there are those round points that can be inserted and adjusted to the face. And when those are seated on the face at a point determined by the operator, now the facebow can be tightened and we can go to the articulator and transfer the relationship of the maxillary teeth to the hinge. Now we have made an assumption here. And in fact, a kinematic facebow and an earbow are both what are called arbitrary facebows. It's arbitrary in that there will be some assumptions made by the operator. In a kinematic earbow, a kinematic facebow, what is decided is I will pick out where that is, where you hinge. I will mark it, that will be my landmark. In an earbow, the assumption is that a certain distance forward and in from the ear canal is where the true hinge axis is. So earbows make an assumption. Earbows insert into the ears so that they can transfer hinge axis based on that assumption. And again, they come in all shapes and sizes, and here you see an assortment of them. Most of us have had experience with an earbow because they're easy, because they're fast. And for 99.99% of the cases that you treat, any clinical decision that you make based on an earbow mounting would not be different even if it had been mounted with a true hinge axis facebow. So for most of us, because efficiency is important, we're going to use earbows. If we run into difficulties, then it may be necessary to go back and gather more information using a true hinge axis. In many practices, that would mean referring that case to a prosthodontist who has that as an ongoing skill they do throughout their practice, because if it's something you don't do regularly, then it's not only difficult, it's inefficient. The earbow that we use for the SAM, like all the others, is quick and easy. It applies and it makes that assumption that the hinge axis is a certain number of millimeters, and I believe in this case it is 6 millimeters anterior and in from the ear canal, the position of that in the ear canal. What you notice on the picture is, remember that this is a circle. And because it is a circle, we can gather the relationship to the hinge axis at any point on that circle. And this is where the facebow now becomes a tool for aesthetic information. We'd like to try and gather it at a specific place on that circle so that we can better apply that in the laboratory. And for that, we need to understand what the patients look like. It's an assumed hinge axis based on that down and forward, but we're now going to try and position the teeth as they truly are in space with that patient. Inserted in the ear canal, we get a mounting. This mounting we would like to have mimic our patient. If it is an accurate mounting relative to hinge axis, but the teeth are not in the right place when we look at them and we have to move the cast up and down, it makes it more difficult for us to make decisions about what would be most appropriate for the patient. It makes it very difficult for the laboratory. So one of the things that we want to talk about with facebow mountings is how do we take that information and replicate the functional movements of the patient while still getting good aesthetic information. Replicating the functional movement of the patient, again, is only dependent on getting it the correct position relative to the axis. And what you'll notice is these lines represent the teeth, and as the patient opens, the mandibular teeth are not only dropping down away from the maxillary teeth, they are also dropping backward. That arc is an important arc. However, that could happen anywhere on that facebow position. So to get aesthetic information, what we'd like to be able to do is go in and say, how do we align the facebow so that as I'm standing and looking, if the earbow is being taken on me, so that when the casts are mounted and the technician, which might be you when you're working up your case, is looking at those mounted casts, do I see my patient as I would see my patient standing and looking at horizon? As you know from our courses here, one of the most important things that we can do is figure out a way to freeze where that patient is as they stand and look at horizon, with lips at rest so that we can make decisions about how would we change aesthetics. How does the face create the great frame for those teeth? Well, those teeth have to be positioned in a way that when you're looking at casts, you know where they are relative to space. So in this case, what we try to do is level the ear bow with the floor. There are a couple of devices that can be attached to ear bows, even the SAM one. Some people will use their SAM as you see here, and when you look at this, you'll notice that the only positioning is going to be relative to the floor, and there's a level that's out on the end of it so that we can level it. And we can turn the level to not only level in this plane, we'll level it in this plane. We have to assume here that we have our patient looking out at horizon to do that. All the systems come with some third point of reference. And in this case, the third point of reference is what's called Nasion, the device on the SAM ear bow that allows you to take the device and rest it. And Nasion is going to sit right up on the bridge of the nose. In the picture you see here, it's being inserted into the ears, the ear bow, and then Nasion is going to be positioned so that it settles in just above the bridge of the nose. There's a problem with this. In some patients, as they stand and look at horizon, that ear bow is now going to be tipped up relative to the floor, relative to the benchtop, and hence relative to horizon. And the mounting that we get will give us a different picture of where those teeth are anterior posteriorly relative to each other, again as the patient stands and looks at us. Leveling it this way as we stand and look at the patient is actually much easier for us, because as we look at that, we know what looks right. Okay? And sometimes what you'll find is that a patient with Nasion will be straight across the front because that's an easy one, but when we shift to the side, we'll notice that in fact it's tipped up. Now, all of the previous ear bow pictures clearly illustrate that we can easily replicate what the patient does. It doesn't matter where it goes. But if we want to transfer aesthetic information, now we've got to figure out some other stuff because that ear bow's got to be lined up, as I talked about, from the side, sagittally. What kind of things do we want to know, and why is that so important? Well, facially we want it level so we can see midline. What I know is the most common error that patients will notice is a midline that is canted. A canted midline is a bad day for the restorative dentist. As you know, patients will recognize and see a cant as small as 1 degree. It doesn't take much cant for the patient to say that doesn't look right. And there is nothing for me more disappointing than trying in a case and realizing that I have a cant. How do you avoid that? You make sure that when the patient is standing and level and looking out at me straight on or at horizon, that when I mount that face bow, it is parallel to the floor. That's going to allow me to make a perpendicular, which will now always be perpendicular. What you also might remember from other courses is that where it is matters much less. In fact, we have an 8 millimeter area to work within because 4 millimeters each way was not noticed until it got to 4 millimeters by lay people. Dentists noticed it at 3, and orthodontists as a subgroup of that noticed it at about 2. Midline position is less important than midline angulation. The face bow is a great tool in getting that one right. It also then is going to help you create a nice incisal plane, because it's not just a midline that we might notice is canted. If we cant that incisal plane, in many cases, the patients will not like how their smile looks. Now, of course, this one is going to be relative to what their lip does, and an asymmetric lip and a smile where the lip is very asymmetric may actually benefit from a slight cant. And that's something that you would figure out in provisionals. However, wouldn't it be nice to know that you created that cant with purpose and intent to get the result that you wanted relative to that aesthetic smile? And that is the key to why we want to take the face bow, so that we can control the variables. Incisal and occlusal plane, it lets us see what's the relationship anterior to posterior, because one of the other tenets of an aesthetic smile that you know is that as I stand here smiling at you, if my anterior teeth appear shorter than the buccal cusps of my posterior teeth, I will have what is called a reverse smile line. And as you know, we find those not pleasing. Pleasing smiles are either level or in the anterior, they are slightly longer as the patient stands and looks at horizon. So occlusal plane now issues can be seen, but also, and more importantly for aesthetics, that plane relative to that anterior can be seen. When the facebow is positioned then, and the patient is holding it, which is possible, and that's what you see in this photograph, what we want is lines that are parallel to the floor as they go right to left, and then lines that are perpendicular to that floor as we look up and down. We want to create planes parallel to the floor, which are also going to be parallel to the benchtop, so that as the technician now sits and looks at my case, they also know when they're building it what is parallel to the floor, and that is parallel to the benchtop. Okay? From the side, sagittally, we want the same sort of relationship. We'd like to create parallel to the floor as we come this way, so that that plane is transferred beautifully. Now, the facebow, if transferred that way, is going to allow us to see in teeth things that are really in nature. If you look at this mounting, what you might notice is there's a cant to the mounting. When this mounting is sitting in front of you, do you know if that cant exists in nature as the patient stands and looks? No. I'm relying on my facebow to tell me that in fact the facebow is taken at a parallel position to the floor. That's the line you see. And the difference between that and the cant actually exists. Now, if I wonder that, one of the places I will always go is back to photography, and we'll talk about that in a second. We try to create redundant systems in our dentistry so that as we move along in a process of diagnosis and treatment planning and then eventually of treatment, we create the ability to back up and evaluate where we've been or to answer questions that we encounter. And for me, if I sit down and I look at this mounting, my first question is, I see a cant, I wonder if that's real. Yes, it is. I can look at my photos or I can go look at my notes. I remember that in fact this patient had that cant. And in fact, my facebow was parallel to the floor. This is one of the best photographs to grab if you want to be able to go back and look at that. And it's one that I grab often, if not every time, I take a complete series of photos with a patient. In this photograph, what we can clearly see is the teeth and the eyes. Now, one of the first observations that I make with patients when I walk up and say hello and begin to speak with them is that as they stand there, and they may move, they may tip their head as they speak, but at some point they'll level and kind of look out at horizon. I try to see if those pupils are parallel with the floor. If pupils are parallel with the floor, they can become a great tool in photography to now go back and correct images so that we can look at the relationship of the eyes to the planes and say, are those casts mounted correctly? Now, it goes farther than that, of course. What we really are asking ourselves is, how would we change what we see there to create a more pleasing result aesthetically? Because generally, if the teeth are parallel with the pupils of the eyes and the pupils are parallel with the floor, the smile is pleasing as long as the incisal edges are at the right place. My job is to put those at the right place, and this tool is very important. If I know that the eyes are parallel with the floor, I can now go down and draw a line across where the teeth are in a photograph and decide what changes I should make. Now, there is one key caveat to this. It's important that this photograph is shot with the lens coming in at the level of the occlusal plane. So I'd like to have my image being shot straight in here. As I'm standing comfortably, you'd be taking that image with the lens down here at this level. If I go higher or lower, what I can do is, relative to this line up here, which is being shot in one plane, right? There's only one plane where my pupils are. This one is being shot in a plane that extends inward. So what I'd like to have is this plane level as it is as I'm standing. Now that might mean it's canted in reality, and I would be able to see that. So grabbing this image can be a great image as a redundant information source. It also is a vital image in going back and correcting the photography even on your close-ups. In some cases, as I said, using Nasion will create a facebow that's level with the floor. It's important that we look at that and not get pulled into just doing it the way it was designed. The SAM earbow, for instance, was designed to use Nasion as a third reference point. What that does is move the plane that will be gathered by the Facebow up and down depending on where Nasion is. And what you might notice in this patient is that with Nasion in position, that's the arrow, that this patient is pretty much level. I'm going to show you in a moment someone who's not. Here she is. If you look at this patient now, what you'll notice is with Nasion positioned, the third reference point as recommended by SAM, the earbow does not look level with the floor because she is standing and staring out into space the way that she stands. Now we could get into some other issues. There might be forward head posture. There's all kinds of other things we can think about. But if we drop this down and talk about basically gathering information means how does the patient look at the world? And then how can I relate that using the Facebow? You'll notice that this Facebow is canted up. There is an upward cant to the Facebow so that when it is gathered, even though Nasion is in position, when I go back to my articulator, that Facebow is going to move down to the line you see now. That lower line is a line that's parallel with the bench. That is how the Facebow is designed, to always return to parallel with the bench when it is used on the articulator. It's why we teach paralleling it with the floor when you gather that information from the patient. If we put a model of the patient's teeth now in there, and we're gathering that with our Facebow jig, what we're going to be doing, if we look at this, remember there's a cant that goes up. It's going to return to that level because here's what it does on the articulator now. It's going to level with that articulator. Ideally, the patient's position in space is as you see it here, with the occlusal plane level with the floor. What's going to happen? I take the Facebow this way. I mount the case. Remember, it's going back to an articulator. And when I put it on, what's going to happen is that cast will now move down in the anterior as you see there. Let me show you that again. That's the patient's actual position in space as they stand there. But when I move it to the articulator, what will happen is because the articulator, or the Facebow was gathered at a position where it was canted up, because Nasion told us to go there, when we mount this case, the anterior will move down. And now you see what happens. Now this, for many of us, looks like a familiar mounting. For many, many years, I used Dinar and Hanau articulation. Wonderful machines, great tools. The difference is that using their Facebows and their third reference points almost always will give you this mounting because they are designed to use a different plane. They use Frankfurt horizontal. So that when you use that with your earbow or your Facebow and go and mount the case, you will almost always have this drop down of the lower anteriors as you see in this picture. And so for many of us, that became what we thought things should look like. But in fact, if you begin to look at patients in your practice and ask them to stand comfortably and then let their teeth part, start observing that in most patients, the incisal plane, the occlusal plane are pretty level, and both of those are pretty level with the floor. Now, that's not what those mountings look like. So when we mount, again, we want to try and level our Facebow, whether or not we use Nasion. Nasion can still be used as a rest point, but it is no longer our reference. Our reference is going to be the actual Facebow and getting that parallel both across the facial and sagittally. And if we can level that, we know that that information now on the articulator will be accurate. How does that change things? Well, as you see on this mounting, if I mounted it at Nasion, for the lady that you saw, and then I put it on the articulator, that's going to be my mounting. If I mounted it the way it actually is in space and gathered that and transferred it to the articulator, that would be my mounting, because her occlusal plane is actually level with the floor. From the facial, it looks like this. If I'm looking at a mounting facially and those anteriors are lower, in actuality, those anteriors and posteriors are quite level. And now I'm looking straight in at the patient as I would if that patient were standing in front of me. Now, one of the last things that we want to do here with a Facebow, and one of the important things, has to do with restorative dentistry. And it has to do with putting in cases as we complete them, minimizing adjustment time at the chair. The reason that happens is that if you remember back to the image I showed of the patient opening and the levels of the teeth, that as the mandibular teeth drop away, the teeth move not only down, they also move back. There's an arc there. Capturing that arc correctly means that it's easy to take two shapes with a lot of points and little grooves and bring them into each other correctly. In other words, there won't be interferences. Now, for most of us, interferences when seating cases were part of seating cases. I expected to adjust things. In fact, before I regularly mounted all my cases on an articulator using a Facebow, I spent substantial time adjusting, not just side to side, just in closing. The reason was that the bite is always correct where it's closed, but the arc that it took to get there was not captured by my records. So while the laboratory did their job completely, they built with the information I gave them. When the patient opened and went to close, there were points that ran into each other as they tried to seat into each other. Now that is going to be minimized if I have captured the appropriate arc. Now, of course, in a busy practice, it's vital that getting a Facebow doesn't take all day. And I would tell you, for those of you who have done pantographic tracings, you know that there is a big time investment. It's why most of us shied away from it. It's why most of dentistry pushed away from it and said, I can't do that. I can't afford to do that because in most cases I don't need all that information. Now, if you decide, and I hope you will, that the information you will gather by taking a Facebow is worth the time invested because the time is minimal, know that it doesn't have to be you. In fact, for years, I took none of my Facebow transfers. They were taken by my team. My assistant was equally skilled. In fact, I'll go further than that. After a while, she was probably better skilled than I because she did them all. And when she mounted that case and looked at it, she knew how to evaluate. Now, she knew how to evaluate in the face because we worked together to make that happen. Facebows are an important part of a high-quality practice. They help us get information from the patient, transfer that information to our laboratory, and then minimize the time that it takes us to work with cases and seat things. Those are all win-win-wins in my book, and I hope they are in yours. If you have questions about Facebow transfers or how they fit into the SPEAR education curriculum, please email me and I'd be happy to talk to you. I want to thank you for spending time with me in this course, and I look forward to seeing you in the next course on our online continuing education. Thank you.